Welcome to Physiology of Nausea and Vomiting and Pharmacology of Antiemetic Drugs. Now, whereas a lot of our other lectures were integrated, this one will have a separate lecture from me on the pharmacology and then a separate lecture on the clinical utility of the pharmacy practice. I added just a tiny bit this year from previous years, a little bit more on scopolamine receptor targeting, and I just wanted to prepare you that the layout of this lecture is different from some of mine. And that is because I talk about a lot of the drugs together on a few slides, all the receptor targets, and really just as a group. And then anything that I wanted to point out about unique differences in the drugs, I'll do that. There's only a few slides that talk about individual drugs. So these are my learning objectives. I don't want to read through all of them, but I just want to say that there's just going to be a few points where I talk about something that may not be written in the slide. So I think it's really important to listen to the lecture and to read through the slides, especially when it comes down to specific areas like the dopamine antagonists causing motion disorders and that kind of thing. So please do your best to focus and write notes on what I say, particularly if you're not seeing it in the slideshow. So this lecture was originally in the oncology module. So I have quite a bit of a focus on like toxicants that might be in the blood or the GI tract, but I did add, the other type of nausea and vomiting that's caused by motion sickness. I did add that, and we'll talk about that later on. So I am trying to be as thorough or comprehensive as possible. Okay, so the major sites in the body for detection of toxicants to trigger vomiting. This means where does the body sense these are kind of assailants or toxins. The stomach and intestines are innervated by the vagus nerve. There's a vagus nerve there, the sensory branch. That can be stimulated by toxicants, resulting in signals to the brainstem to induce vomiting. So that's the first anatomical location that would be in the gastrointestinal system, which is probably obvious, right? You eat something that's poisonous, a lot of times your body will induce vomiting very quickly. The second one that may not be as obvious is the chemoreceptor trigger zone, and that is in the medulla, in the brainstem. So believe it or not, so that's right in the brainstem. So that means it's not going to immediately detect toxins that are in the diet or something that you consume, but it's actually designed to detect toxins that are in the blood. And this is one of the rare locations in the brain or in the central nervous system where we have kind of the leaky capillaries there, and we don't have a tight blood-brain barrier in the chemoreceptor trigger zone in the brainstem, so we can very easily sense toxins that are in the bloodstream. So just a little bit of a kind of really background on the biology or why does nausea and vomiting exist. It's really it's pretty obvious, right? It's to protect the body from ingested toxins, spoiled foods, or infectious agents. It's known as one of the most powerful behavioral deterrents, whereas a lot of times you can't remember. Some people might not be able to remember what they did yesterday. If something made you nauseous, the chances of you forgetting about that are very slim, right? That's one of the most powerful deterrents. It's more active in certain instances. The kind of trigger. The trigger for nausea and vomiting is more active in certain instances, such as in early in pregnancy. That's not 100% proven as to the reason, but it's possibly to protect the fetus from toxins. But we know a lot of women will get sick either way, even if they're not exposed to a toxin. So it's kind of strange, but it does happen. Yeah, so that's why I have just maybe as an unnecessary burden. So it's not always obvious as to that exact reason during again early in labor. So this slide is just kind of a warm up to the main neurotransmitters that I'll be talking about, and then I'm going to have I hope I don't overwhelm you too much, but the next slide is going to be really where all the receptors are in the body, just a basic schematic of the receptors that are important for nausea and vomiting. So one of the main ones is serotonin. Serotonin, these are the neurotransmitters, not the receptors yet, that are in bold here. Serotonin is probably the most important neurotransmitter in nausea and vomiting. And the reason why we know that is because the drugs that block it are some of the most effective drugs for nausea and vomiting. And that would be particularly the 5-HT3 receptor antagonists, because the 5-HT3 receptors mediate a lot of the emetogenic action. That means emetogenic means vomiting action or propensity to trigger vomiting. 5-HT3 receptors are on the vagal afferent nerves. So those are the sensory nerves in the GI tract. So if there's something irritating the intestines or stomach, that will be triggered. But 5-HT3 receptors are also in the chemoreceptor trigger zone in the medulla and another portion of the brain called the solitary tract nucleus. So they're really in a lot of different locations where nausea and vomiting would be triggered. Dopamine is another neurotransmitter. The receptor D2 is in the CTZ, and that is, again, a pro-nausea and vomiting receptor. So if that's activated, we can get nausea and vomiting. Substance P is, that's a unique one, and that has not, the drugs for that have not been out that long compared to, like the 5-HT3 antagonists and the other ones. But substance P is unique because it appears to be more important for delayed nausea and vomiting from a toxin, particularly chemotherapy. So if someone has chemotherapy, they may not get nausea and vomiting immediately, but then, maybe a day later, or even, who knows, even longer. It appears to be related to this thing called substance P, which is released when certain cells are destroyed. And this is you can call it a neurotransmitter, but it's also released from other cell types. And that activates the neurokinin 1 receptor. So NK1 receptor antagonists are useful for delayed chemotherapy-induced nausea and vomiting. Really any type of delayed nausea and vomiting. Histamine and acetylcholine. Histamine and acetylcholine appear to be most important in the inner ear vestibular apparatus. So they're involved in motion sickness. And they don't seem to be as useful for a toxin or poison that is going to trigger nausea and vomiting. So if someone is on, if you're on a chemotherapy drug or, well, I'll just stick with that, but because that's kind of what I usually talk about. But the chemotherapy drugs that would trigger nausea and vomiting, you wouldn't generally use an anticholinergic or an antihistaminic drug to treat that chemotherapy-induced nausea and vomiting, because that's not really motion sickness related. Okay, so this is a slide that I know is a little bit overwhelming at first, but I don't expect you to memorize every single arrow and every single portion of the pathway. But what I want you to understand is where the receptors are located, so why you would choose a specific drug for a specific type of, of nausea and vomiting. So, like I said, the inner ear, which would be the vestibular apparatus, would have histamine, several different histamine receptors, and also several different muscarinic receptors, and that's why we use those medications for motion sickness. And I have more detail on that later on. But why don't we go back to basically what happens when first of all, if you ingest a toxin. So if you ingest a toxin or toxicant, okay, and again, this is the stomach or small intestine. It could be a cytotoxic drug. I just put copper sulfate there because that's a very strong emetic. Even damage to the stomach or small intestine through radiation, if someone is getting radiation for a cancer, even the radiation could damage those cells. And when those cells are damaged, they release certain neurotransmitters, like I said, substance P or serotonin, and that excess release causes nausea and vomiting. Bacteria and viruses produce toxins that can also cause nausea and vomiting. And that's just things that are ingested or that are in the GI tract. There are also bloodborne emetics, right, or things that are in the blood that cause nausea and vomiting. It could be cytotoxic drugs, opioids. An old drug called Ipecac used to be used intentionally to induce vomiting in someone that ingested something toxic. That's not really used anymore, but it's just an interesting example of something that could be in the blood and also induce nausea and vomiting. Something I want to clarify is that just because something is in the blood doesn't mean it doesn't affect the GI tract. Remember, the GI tract is loaded with capillaries, so a bloodborne emetic can potentially still irritate the stomach and small intestine to trigger those receptors in the vagal afferents there. Also, though, as I mentioned already, the bloodborne emetics are directly permeant. They can permeate the chemoreceptor trigger zone. And what this is supposed to be, this is not anatomically correct, the layout of this, but it's supposed to mean that the top here is like, once you get into the central nervous system, the bottom is the peripheral, the rest of the body. The blood-brain barrier, remember, that's just the capillaries in the brain. Now, the chemoreceptor trigger zone, I'm just trying to show you that that is exposed. That is not guarded by tight junctions and capillaries. So this is just to show you like the effective layout. It's not really, again, it's not anatomically correct. The chemoreceptor trigger zone is not going to look like that, but it's basically just showing you that that is exposed. So if something is in the blood, it has direct access to the CTZ, or chemoreceptor trigger zone, and the main thing is the receptors. So if I say to you, if you use a 5-HT3 receptor antagonist, where would that work? It would work in the CTZ, the gastrointestinal system. Another portion of the brain is the solitary tract nucleus. Okay, so it's in many, many locations, and that's why, again, the serotonin receptor antagonists appear to be really the most effective drugs for, especially like chemotherapy-induced nausea and vomiting, or toxins that are ingested. Okay, and that's the main idea. Just that a lot of these receptors are in multiple locations. Some of these locations communicate with each other. For instance, the GI tract the neurons will travel, like the vagal and sympathetic afferent nerves will travel up, and some of those will innervate the CTZ, some of those will innervate the solitary tract nucleus in the brain. And ultimately, all this comes together and merges or converges on the emetic center in the medulla. The emetic center is where the sensory portion stops, and that's going to then turn into a motor portion. That means after the signal reaches the emetic center, that's when you're going to start to have the motor response. That means like the retching, the gastrointestinal system might, it'll start to constrict to move things upwards closer into your esophagus. So that's the motor response that happens. It happens after that. Everything on this slide, other than the emetic center, is really just the sensory, right? This is the sensation of toxins or sensation of something to trigger nausea and vomiting. And I don't want to miss this. You can actually have triggering nausea and vomiting just through pain, smell, or sight, right? Or memory, fear, dread, and anticipation. That means if something made you nauseous before and you anticipate experiencing that again, even if you haven't experienced it yet, just that anticipation can trigger nausea and vomiting, as most of us probably are aware. So a lot of that stuff, that anticipatory nausea and vomiting is not really treated with standard antiemetics, because that's more of an anxiety. So it would be, be treated with standard anti-anxiety medications, maybe benzodiazepines. So that's not really the focus of this lecture. It's mostly on, we're talking about things that directly block these receptors related to nausea and vomiting. Okay, this slide is just to emphasize the importance of serotonin in nausea and vomiting. And I want to clarify, because this has happened before, the serotonin is 5-HT. The serotonin receptor is going to have the subscript, that's 5-HT3. Again, serotonin is probably one of the most important neurotransmitters. It's definitely one of the, if not the most important neurotransmitter in nausea and vomiting. And the way it works is, again, this is the intestinal lumen. Just imagine you ingested something that was damaging or irritating these enterocytes. If this gets damaged or irritated enough, it will release an excessive amount of serotonin, and that serotonin will bind, and you can't see it here, but there'll be receptors on this neuron. This is a vagal afferent neuron. The receptors on that will be activated. That'll send a signal all the way to the the chemoreceptor trigger zone, or the solitary tract nucleus, but essentially into the brainstem or the brain itself, and that will trigger nausea and vomiting because that'll go to the emetic center. Something that might not be widely known is that more than 80% of your body's serotonin is in the enterochromaffin cells. That's not the same as the ones in the stomach called ECL. These are different cells, but the enterochromaffin cells are they're enterocytes. They're basically just lining the intestinal lumen. 80% of the serotonin is there, and that's for the whole body's serotonin. So that means the brain has a lot less than the GI tract, which is really interesting. So when people talk about serotonin as, oh, it's so important for being happy, if I couldn't even have spent an hour talking about everything that serotonin does, we still wouldn't have enough time to really complete it, to complete that discussion, because it does so many things other than affect mood. And this is one of the things that does, and it's the trigger for nausea and vomiting. So what happens is, again, like I said, the serotonin is released on the basolateral side, and the signal goes up. This causes CTZ and solitary tract nucleus activation, and that stimulates the emetic center. If you're like me, a lot of times when people start referring to the brain or the brain stem, it's hard to really picture specifically what we're talking about or what region. So I wanted to point that out. I tried my best to pinpoint that. So the chemoreceptor trigger zone would actually be right around here anatomically. The solitary tract nucleus will be right around here in the brainstem. Okay, and those communicate with each other, but again, the main point is that the CTZ does not have tight junctions in the capillaries there. It just means that you can easily sense bloodborne toxins. I'll just hurry up because this is just a simple animation, but we already kind of talked about all this, but just illustrating what happens. Most of the brain, toxins and things, they travel right through, right? And then they'll travel right through and then they'll go back, essentially go back to the circulatory system, the rest of the body. However, in the CTZ, one more time to the animation, then the CTZ, things will go in and irritate that. The cells can be irritated and release neurotransmitters that will then trigger nausea and vomiting. So just to emphasize that difference, that most of the brain is protected, CTZ is not. I just have one slide on really what happens after activation of the emetic center, and this is the motor response. We don't usually use medications that affect this pathway. Most of the medications are blocking the sensory pathway, so that's why I'm not going to spend a lot of time on this. So the emetic response is mediated by various efferent neuronal pathways that would include the efferent vagus nerve, phrenic nerves, and spinal innervation of the abdominal musculature, as you might imagine. So the sequence of events is nausea is first, obviously. I don't know if you would have thought about this before, but it's interesting. The gastric tone is reduced, so the stomach contractility is reduced. Gastric peristalsis is reduced or absent, so the stomach actually stops churning. The tone of the duodenum and upper jejunum is increased, so you're squeezing that duodenum and upper jejunum, and it's almost like the body's like trying to, like a tube of toothpaste, trying to squeeze the contents upwards, and it really is doing that. So you squeeze the duodenum and upper jejunum. The stomach is not constricting, so the stomach is free to receive more chyme from the intestines, and then gastric reflux occurs into the esophagus. The actual vomiting is that the upper portion of the stomach relaxes. That would be, for instance, the fundus and the esophageal sphincter would relax, while the pylorus, which is in the bottom of the stomach, that will constrict. And then you have coordinated contraction of the diaphragm and abdominal musculature that leads to expulsion of gastric contents. So it's like reverse peristalsis. You're squeezing everything to move it in the reverse direction, obviously, of normal. So with that last piece of knowledge, now you should understand that nausea and vomiting is going to only really occur if we have the movement of intestinal contents backwards. So the opposite holds true. If we can actually promote peristalsis, there's good evidence that we can reduce vomiting, right? It doesn't necessarily, we can't guarantee that it'll terminate the nausea feeling, but we can reduce vomiting by stimulating peristalsis to move intestinal contents in the correct direction. So we're back to the same thing that we've seen before for constipation, diarrhea. And this time the highlight is going to be on the dopaminergic neuron rather than the opioid neuron, but they're both going to affect this. Now remember, this terminal cholinergic neuron would stimulate the circular muscle to contract, and that would help peristalsis. Okay, remember, so if the dopaminergic neuron releases dopamine, okay, that released dopamine, that would actually slow this down. That would stop this. So what that means is the D2 receptor, if that is activated, we have lack of intestinal motility, and that can actually result in more vomiting. So the opposite holds true, and what this is called is prokinesis. If we block D2, we use a dopamine receptor antagonist, that will allow this neuron to release more acetylcholine at the appropriate time, but it will have more intense peristalsis, and that just means that the intestinal contents will move in the correct direction. So dopaminergic antagonists are called prokinetic agents because they promote bowel motility and they reduce vomiting. So this is going to be one of the most important slides pharmacologically. What I've done is summarized the receptor targets of the main drug classes used in nausea and vomiting. And you can see some of them are promiscuous in that they cover maybe 3 receptors. Some of them are very specific, that they're covering 1 receptor. And we can start from the top, it doesn't really matter, but I'll start there just to explain. So what does this mean? So anticholinergics, scopolamine. Scopolamine is one of the few drugs that's it's not really binding to any of these other receptors. Its main function is to bind to muscarinic receptors. And this is actually pretty non-selective, so it could bind to M1, 2, 3, 4, or 5. And that's why I have that in the column on the right. All these drugs that have the pluses on them, they block all those muscarinic receptors non-selectively, so they're not going to target a specific one. Scopolamine is a very muscarinic specific antagonist. This drug is still, you can find it naturally in certain plants. It's considered a belladonna alkaloid, so it's one of the few drugs that are still found naturally. Specific one of the few drugs for nausea and vomiting that are found naturally. And we'll talk about that later, but because it is a muscarinic antagonist, it's going to have a lot of side effects, and a lot of those are related to sedation. Also, because scopolamine, because it works on motion sickness, it must also get into the central nervous system. So it has to be lipophilic enough to cross the blood-brain barrier. If you think of anticholinergics, you might think of also atropine. Atropine is not used for nausea and vomiting because, first of all, the cardiovascular effects are very strong, but second of all, it doesn't cross the blood-brain barrier very easily. So if you injected atropine or swallowed it or something, you wouldn't get a lot in the central nervous system. So it wouldn't really help nausea and vomiting, whereas scopolamine does cross the blood-brain barrier quite easily. So you'd use it specifically for motion sickness. And that is the interesting one that could be used transdermally. So in some cases, up to 3 days, you can get therapeutic effect if you put the patch on. Or they might have other transdermal delivery systems nowadays. Antihistamines, a lot of these you might be familiar with: diphenhydramine or Benadryl, dimenhydrinate, doxylamine, hydroxyzine, meclizine, and promethazine. All these antihistamines, especially the ones at the top here, they work on H1 receptors, not really H2. So the H2 would be, like your acid suppressant therapy, so cimetidine and ranitidine. So we're not talking about that. These are H1 receptor antagonists, but they also have muscarinic receptor activity. Now, you might be asking, what does that really mean? Like the pluses there, what do those mean? And I try to make it practical, and I didn't want to give you numbers. I mean, the numbers in the literature in terms of affinity, but I just wanted to understand that basically if I have, 3 or 4 pluses there, that means it's pretty strong. And the pharmacological potency is not as important as, how much activity do you get based on the dose? Because you could have low potency, but then give someone a higher dose and get high activity, right? So that's more important. So we find out that we know these antihistamines have H1 receptor blockade effects and muscarinic receptor effects. In fact, the only ones we use for nausea and vomiting have both H1 and muscarinic receptor activity. Promethazine is interesting because that blocks H1, D2, and muscarinic receptors. So this is the only one out of this class that can block D2, and that means it has some prokinetic effects. So some potential advantage there because it can stimulate peristalsis and also prevent nausea and vomiting potentially. So promethazine might potentially be used for things other than motion sickness. And that's why I wanted to point out that dopamine effect. Because any D2 antagonist can potentially help with things other, nausea and vomiting other than that triggered by or because of motion sickness. So it has a bonus effect. Haloperidol, I don't think is used very often for nausea and vomiting, but it can be. It is prokinetic, which is D2. Okay, one thing I'll add, I think this will come up in the clinical side, the clinical lecture, but one thing I'll add is any drug that blocks dopamine 2 receptors has a risk of a side effect called tardive dyskinesia, and that means someone can it'll resemble Parkinson's disease, where they'll have some uncontrolled muscle activity like rolling of the tongue, other uncontrolled facial motion, and you might have seen the lawsuits on TV because some of the patients that get that tardive dyskinesia-like effect, they can have that for life, and that's even after you discontinue one of these drugs. So the D2 receptor antagonists have that rare side effect that's, if you get it, it's really, really bothersome because it'll look like Parkinson's disease, and sometimes it's irreversible. So I would not say that these would be, we know they're not generally first line compared to, for instance, the serotonin receptor antagonists, which are much safer. So again, the serotonin antagonists, these are just some examples, but they all have cetron in them. Remember we talked about elocitron in, what was that? That was for diarrhea, IBS diarrhea, but these are pretty much the same receptor targeting, but these are not used for IBS diarrhea, whereas elocitron is. So it just, even though they have the same mechanism, they're used for different purposes. So these are very specific 5-HT3 receptor antagonists. And so what do you actually need to take home from this? Like you need to be able to tell me then, like, so if based on what receptor they target, you should be able to tell me like where in the whole pathway do they work. Do they work in the intestines? Do they work in the CTZ? Do they work in the solitary tract nucleus? And the answer is all three. So connecting the physiological or anatomical location with the receptors and the drug is really going to be important. Next would be phenothiazines, such as prochlorperazine or compazine was the old brand name that you might see from time to time. That is similar to promethazine, except it doesn't really have. Actually, I don't think I looked it up, so don't worry about that. But I didn't. So in terms of muscarinic receptor activity, I'm not 100% sure. But I wanted. It was more important for me that you understand that it's that dual histamine D2 effect. Okay, and a little bit of serotonin, which is not that important. But prochlorperazine is again. And I don't think it's often used for motion sickness, but it does have the H1 effect, but it has a D2 effect, which means it's prokinetic. NK1 antagonists like aprepitant, and now there's a bunch of other ones that end in that PITANT. Any drug that ends in that, in almost all cases, I think that's going to be an NK1 antagonist, but it's always good to double check. But those are generally reserved for chemotherapy-induced nausea and vomiting, or delayed nausea and vomiting from from a toxin. And then finally, benzamides such as metoclopramide, that's another one that blocks D2, but that has a little bit more serotonin blocking effects. So metoclopramide is pretty good for nausea and vomiting. It's again because it has a dual blocking that all that sensation of it could be chemotherapy, but a sensation of a toxin, and all those organs or all those sites that we talked about in for sensation of toxins, like the CTZ, the intestines, and the solitary tract nucleus. But metoclopramide is also D2 antagonist, so it's prokinetic. But again, that's another one that has the risk, and I don't know, it's a very low risk. I don't know the exact number, but there is a risk of that tardive dyskinesia-like effect because it's the D2 antagonist. So it's that prokinetic effect always comes along with that other risk that we're not really interested, obviously, in having. Okay, so I just have a few slides on each specific, the major drug classes that I actually wanted to point out. Not every single drug class will have its own slide, but just a few of them. So the 5-HT3 receptor antagonists, just understand that they compete for the 5-HT3 receptors on all three sites that we talked about, and that means they're central and peripherally acting agents. In most cases, liver function will influence clearance. Okay, and I just wanted to show you structurally how they resemble very much serotonin. Next, D2 receptor antagonists, they mainly block dopamine in dopamine receptor activity in the CTZ. And I should have mentioned that earlier, but remember, back at that image with all the receptors, dopamine receptors they're there. They're in the CTZ, and that's where you sense toxins. And I also mentioned that the dopamine 2 receptors are also in the enteric neurons that are going to help to trigger that prokinetic effect. So there's that dual effect of, if you block a D2, you're blocking the sensation of a toxin. You're also causing prokinesis. So it's really the sensory and the motor pathway that you're affecting. Prochlorperazine is unique because it's better at preventing motion sickness primarily due to its anticholinergic and antihistaminic effects. Metoclopramide is also it's prokinetic as D2 effects, but it's also 5-HT3. So it's still out there, and I think it's pretty commonly used. It's been like that for many, many years just because it's quite effective at a lot of different types, for a lot of different types of nausea and vomiting. Okay, so finally is the antihistamine / anticholinergics. Now I have to kind of warn you that the physiology of this is not completely understood. They've just identified a lot of histamine receptors, pretty much all of them, I believe, in the inner ear. They know that muscarinic receptors are involved. I haven't found a reference that shows exactly where everything is located and exactly how it works. So I know they're still studying this. But what we know for sure is that in order for a drug to work and we're going to focus on motion sickness because the antihistamine anticholinergics are primarily used for motion sickness. The only ones that work well they're either just anticholinergic agents or histamine receptor antagonists that have anticholinergic receptor activity. So it seems that the most important effect is the anticholinergic effect. However, we know that histamine receptors exist where motion sickness occurs or is triggered, and that's in the inner ear. So really the jury's still out on the importance of histamine versus muscarinic receptors. So pure antihistamines without anticholinergic activity are not used. One other thing that's really important is that all drugs in this class must also cross the blood-brain barrier to be effective, as the neurons that are involved in the vomiting stimulus, they do travel from the inner ear, which is the vestibular apparatus, to the brain. Okay, so those drugs have to get into the blood through the blood-brain barrier into the central nervous system to be effective. So these drugs should be pretty lipophilic in most cases if not all cases. None of these drugs alone are useful for other causes of nausea and vomiting. Um, I would say that that's true in almost all cases. For again, if any of these drugs, if any of the antihistamines are used for other forms of nausea and vomiting, it's because they have other receptor effects, which might be dopamine receptor effects or 5-HT3 receptor effects. Okay, this is the last slide. I just have a really basic review of the inner ear. This is by no means going to be, extensive discussion of the physiology of the inner ear, but just a couple of things I wanted to remind you of. The inner ear is filled with fluid. Okay, and some of those organs, such as the utricle there, have something called hair cells. The hair cells, not surprisingly, right, they have hairs on them. And these hairs are absolutely critical for hearing and proprioception or motion sensing. So these hairs have to move, right? They'll move when essentially the gel, there's this gel here, a gel membrane that also has something called otoconia, which are calcium carbonate and protein crystals. Those things, if someone moves, forwards, backwards, left, right, in different positions, the hairs will move as the fluid moves. The hairs will move forward or backward relative to the cells, right? So the cells in the hair orientation will change based on how fast you move and what direction you move in. So the more those hairs are perturbed or mechanically moved, the more signal you will get. A signal to these neurons. These are sensory or afferent neurons. And if you could basically, and this is really simplifying it because it's not very well understood, but if you overstimulate those, some people have an excess sensitivity to that, and that can cause what's called motion sickness. Now, there's a lot of other names for it, like airplane sickness, seasickness. It's all related to the same thing, and that's excessive hair cell motion, and probably it appears to be the rhythmicity of it. For instance, on like a rocking boat, that constant rhythmic motion moving the hair cells appears to be really important. But from a drug perspective, we know at this point we know that many different histamine receptors are involved. Some of those are on the hair cells. Some of those are directly on the vestibular afferent neurons here. Okay, so exactly where the histamine, the endogenous histamine will come from, I'm not sure. I think it's actually released from the hair cells, probably released onto their own cells, like onto themselves or onto the neurons. But we know that the receptors are here. Now, in terms of the this is different. So these are histamine receptors. The muscarinic receptors, they are believed to be later on. If you follow these neurons, and you're not going to see that here, but if you follow these neurons up into the brain, you would find that they synapse with another neuron, and at some point, one of the neurons will release acetylcholine. That cholinergic transmission is important for this motion sickness. So the antihistamine drugs, and like I mentioned, all the ones that are used, they also have anticholinergic effects. So it's really hard to distinguish between the importance of the histamine versus the anticholinergic. But we know that the histamine receptors are here, but the muscarinic receptors are later on in the pathway. But essentially, you need that acetylcholine later on in the pathway, in the neuron flow, in order to trigger nausea and vomiting. And that's the main point. So the drugs that are effective are going to block acetylcholine through blocking. All of them that seem to be utilized now are very non-selective. They block M1, 2, 3, 4, and 5, and they all seem to be effective for motion sickness. Again, the antihistamine drugs, such as diphenhydramine, doxylamine, they're not so standard antihistamine it can be used for motion sickness, but a lot of times they're not. A lot of times you'll specifically see scopolamine or something that's pure anticholinergic. But you can definitely get some efficacy from a standard antihistamine with the warning or caveat that you have to use an older generation. So the newer generations like we'll say loratadine or Claritin, fexofenadine, which actually I don't see a lot of fexofenadine anymore, or cetirizine. Those are all second or later generations, and because of that, they do not have anticholinergic effects. Those are not considered as effective. So you need to use either an older antihistamine that has anticholinergic effects, or just a pure anticholinergic. So that would be the older antihistamines with like diphenhydramine, um, or again doxylamine, something like that. The ones that are in between, I don't know if you're familiar with chlorpheniramine or brompheniramine. Those ones are not that new, but they're not very sedating. And it turns out the ones that are not very sedating are also not utilized for motion sickness. So brompheniramine, chlorpheniramine, they're not utilized for motion sickness. So it appears to me that the sedating ones are used more often, and that sedation effect is because of the anticholinergic effect. So it seems that the acetylcholine is really, really critical to have a good drug for motion sickness. And that's about all I had to say about that. Um, just a little bit of extra information on the bottom. Just that some people are hypersensitive to that rhythmic motion that causes motion sickness.